So welcome to the discussion of the Step 1 Severe Sepsis and Septic Shock Management Bundle. These are just some general observations that we have and also that I've discussed with other abstractors at other hospitals and CDI staff. So these are just some highlights on the Step 1 bundle. I will be sharing the main criteria. There are always variances, and that's the reason why this manual is so extensive, is that depending on the patient condition, there's always variances that are allowed. So I will just be going over the main criteria that they will be looking at. Again, just the highlights of the criteria, not getting into the nitty-gritty weeds. That is up to each hospital, but just sharing what I've observed and also what I've discussed with other professionals in dealing with the Step 1 measure. Just sharing that every effort has been taken by the author of this presentation to ensure that the information shared was as current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to be shared in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information that is shared is only intended as just that, informational, and is not to take precedence over any state, local, federal guidelines, organizational policies, and or procedures, and certainly is not to take precedence over the details and I'm talking great detail, in the weeds of the specifications manual that is effective from January 1, 2020 through 2024 through June 30th, 2024. The specifications manual is updated every 6 months. So I will be going over just the highlights, the general criteria, and not every single criteria, but just the highlights of where some of us have discovered some little stumbling blocks. And so thank you for joining the conversation. So Step 1, Severe Sepsis and Septic Management Bundle is an externally reported measure for all acute care hospitals that participate in the Inpatient Quality Reporting Program, and is reported across the nation as for each individual hospital that has inpatients in an acute care bed. As of January 1, 2024, our performance period with regards to compliance with the elements identified in the Step 1 measure are factored into the hospital payment for the Hospital Value-Based Purchasing Program, which awards quality outcomes for those patients in the inpatient setting of an acute care hospital with incentive payments that are based upon performance. There are 4 areas that each count as 25% of the total performance score: clinical outcomes, person and community engagement, safety, efficiency, and cost reduction. The Step 1 Severe Sepsis and Septic Shock Management Bundle will be in the section of safety with the 5 hospital-acquired infections: CODI, CLAMSI, CDI, MRSA, and SSI. The baseline performance period for Step 1 was January 1, 2022 through December 31, 2022. And we are now in the performance period of January 1, 2024 through December 31, 2024. That will be factored in to the fiscal year 2026 hospital payment. Again, I would just like to refer to the CMS specifications manual for the IQR program that was effective January 1, 2024 through June 30th, 2024 to speak to the details in the weeds of the variances that are allowed for certain clinical conditions that arise with each patient. So this presentation will speak to the coding and the abstraction. So when you can come into the bucket, we call it a bucket, of those that qualify, that population. If your provider has documented that you have severe sepsis or septic shock, or if you meet clinical criteria all within 6 hours of each other. such as an infection, 2 or more search criteria met with the sign of organ dysfunction, all within 6 hours of each other. Now, please note, the clinical criteria for SIRS and organ dysfunction are separate for the pregnant versus the non-pregnant populations. They are different criteria, so just be aware of that. Also, just a reminder, the SEP1 bundle is now part of the hospital value-based purchasing program. This is just a reminder that let's say a patient comes into the ED at 7 in the morning, but they're not recognized as having, they haven't met clinical criteria yet, and they're not recognized by the provider until, let's say, 11 o'clock in the morning, that they have severe sepsis or septic shock. So if the provider documentation is the first time that the severe sepsis or septic shock is recognized, then please document the time that that is recognized, because that starts the time zero that we're able to see if the other elements such as antibiotics, blood cultures, lactic acid are drawn within that 3-hour window. If the time's not documented, then the abstractor needs to default per CMS rules that the date and time that the note was opened or started, which may be much earlier than the time that the severe sepsis or septic shock was recognized. This slide just illustrates that we are looking 3 hours after the identification of the time and date severe sepsis or septic shock to ensure that these 3 elements are completed: blood culture, antibiotic administration, lactic acid collection. If the initial lactate is greater than 2, the repeat lactic acid must be collected in the window that begins after the initial lactate level collection time and ends 6 hours after the severe sepsis presentation time. So the suggestion I have is to work with your lab and IT department to have an automatic collection built into the lab module of the EHR that triggers a repeat lactic acid collection within the specified time frame for any lactic acid that is greater than 2. When certain criteria are met, there is a need to have crystalloid fluid target fluids administration. There's 3 options. One is 30 mLs per kilo of actual body weight. The other is 30 mLs per kilo of ideal body weight. Given the provider has documented that the patient is obese with a BMI greater than 30, that the IBW is used to calculate the target ordered fluid volume, and that the IBW is documented in the medical record. The abstractor is not allowed to calculate it. The third option is less than 30 mLs per kilo under the following circumstances. There is an order for a lesser volume than 30 mLs per kilo, such as a specific amount, for example, like 500 ml or 1500 ml, specific ml, or a specific weight-based volume that is less than 30 mLs per kilo. So that would be such as 20 mLs per kilo, 15 mLs per kilo. Documentation within single source the reason for ordering less than 30 mLs per kilo. So a suggestion I have is to collaborate with the providers in IT and abstractor to build templates that would help facilitate adherence to the guidelines for the SEP1 target fluid administration. So when certain criteria are met, there must be an assessment for the presence of persistent hypotension or new onset within 1 hour post-crystalloid fluid target fluid administration. So an example is, let's say you have a patient at 70 kilos at 30 mLs per kilo equals 2100 mLs over an hour. The infusion started at 9 o'clock in the morning, was completed at 10 o'clock that same day. So the assessment for the presence of persistent hypotension or new onset must be within the time frame of, let's say, today, 3/2/2024, between 10 o'clock and 11 o'clock. So between 10 o'clock and 11 o'clock, there must be 2 blood pressures checked, and in some instances allows for 1. But again, look to the specifications manual. But you need to assess for the presence of persistent hypotension or new onset within that time frame. If it is present, then there must be a vasopressor administered that starts in the time frame window of the time of septic shock was identified and it ends 6 hours later. Another area I cannot emphasize enough is ensuring that we document the repeat volume perfusion assessment that it was performed. If it's not documented by the provider, then the abstractor must look through the notes to find if there's additional documentation. That additional documentation in place of the documentation by the provider stating that there was a repeat volume perfusion assessment completed is ensuring that 5 of the 8 elements below were documented within the window. So if there's no documentation by the provider about the repeat volume perfusion assessment being completed, then the abstractor needs to go to the 8 elements that were identified on the previous slide and needs to locate where 5 of those 8 elements were documented within the window. Now, there's a third option that if those were not done, or in place of them not be done, if any of these 4 tests were completed, then that will qualify for the repeat volume perfusion assessment. So the need for consistency with compliance of all the elements in terms of definitions and criteria is for abstraction is supply support for uniformity of data entry. This is so we can compare apples to apples and oranges to oranges from one hospital to the next in the state and in the nation. This way we will have a relative amount of assurance that each facility is entering data with integrity of adherence to the definitions and the guidelines, so we can compare our facility to the state and the nation with relative accuracy. CMS does validation surveys of all reporting programs. If we do not comply, for instance, they'll ask for a sample of 10 charts. And if we are not in congruence with our findings at least 75% or higher, then we will fail the validation requirement. So we have to be at least 75% in congruence between what the external validator has abstracted for the sepsis case and what the hospital abstractor has abstracted for the case. So if at least 75% or higher of the cases are in agreement, then the hospital will pass the IQR validation requirement. If we are lower than 75%, then the hospital will fail. And this again is to support the uniformity of data entry for each hospital as compared to each region and state and the nation, so we can compare apples to apples and oranges to oranges. And once again, this all wraps around to no money, no mission. Hospital payment and quality of care are getting linked more and more. Back in early 1980, and yes, I'm old, it was always a fee. You charged a fee and you were paid. There was no question about it. Late 1980s, the diagnosis relay groupings were developed, and then later on, it became quality of care is what got you your payment. So all of this is getting wrapped around, and it's all one big bundle, and we all play a part. These are just some of the references I use from CMS and Surviving Sepsis campaign. There's information about validation and the hospital value-based purchasing program, and also the specifications manual that we use for sepsis. It is quite extensive, so enjoy the reading. They put this out, review it every 6 months. So the one that I have on this slide is good for January 1, 24 through June 30th of 24. And there's always slight updates and variances as time goes on. So once again, I thank you for sharing this experience, and I thank you for joining the conversation with us. And I want to hear from you if there's any other videos or disease-specific conditions you would like to discuss. I'm going to have a couple more coming up on pneumonia and substances. And so thank you very much and have a great day. Bye-bye.